So some of my goals for today for you all are to one, be able to define a crisis and what that means, to be able to identify warning signs, how to notice if somebody may be in a mental health crisis so that you can get that person the help that they need. We're going to talk about the questions to ask someone to assess for suicide. Basically not to beat around the bush, to be direct about it. Help you all understand the crisis care continuum and what that is so that you learn the resources if you do come into contact with somebody who's in a crisis for how to best help that person. To help you identify strategies for managing suicidality and a mental health crisis. And then finally, to learn about additional mental health training opportunities. We hope that this isn't the only mental health training that you receive and that you learn about additional opportunities and look to pursue those. All right, so when we talk about a crisis, we have to remember a few things. One, it is individual. And so we always talk about that perception is reality. So a lot of times you may come into contact with someone, I'm thinking of a variety of 911 calls. Usually someone's in crisis, they call 911. And maybe law enforcement, EMS, whoever responds, they get there and they think, wow, I don't know if this is a crisis. I don't know if this was 911. But we have to remember that when someone feels that they are in a crisis, that's how they're going to perceive it, that's how they're going to feel it, and that's the reality for them. So we have to remember that however they perceive the situation, if it's a crisis, then we need to treat it as such and respond appropriately to that. But really, it's any situation where a person feels that they're out of control. A lot of times we may feel that we can cope with certain situations, things that have happened. Maybe it's been a similar situation. But we have to remember that sometimes things compound, and maybe they were able to previously cope with the situation, but maybe something has happened. Maybe there's an additional stressor that's taken place in their life, and now they just feel like this was the straw that broke the camel's back, and they just don't feel like they're in a place to be able to deal with what's going on. But we also have to remember that humans are not born with coping skills, right? We like to think that we're born like a blank slate. And we learn coping skills either through life experiences, maybe trial and error. Maybe we heard about, oh, this breathing technique worked great for somebody. Let me see if that works for me. And maybe it does, maybe it doesn't. But they're also learned from others in the environment. So if somebody grows up in an environment that's very stressful, that's chaotic, they may not learn the coping skills to be able to deal with the situation like you or I may be able to. And then we have to keep in mind that a series of life events can deteriorate that person's ability to cope. So again, they may have been a great coper, so to speak, throughout their whole life, and then something happens. Think about COVID-19. That put a lot of additional stress on people in a variety of realms. With their relationships, they were isolated, they had to withdraw, job security was threatened, finances, losing friends, family members to COVID-19. So we saw an increase in mental health calls just because people were experiencing stressors they never had before. So before I get to the cheat sheet, when you think of someone who is in a mental health crisis, what are some things that you may see, observe, or hear that person saying? How might you know if you saw someone that they may be in a crisis?
Nervousness.
Nervousness, okay.
They're saying something they need to say, they can't say anymore.
Okay, sometimes phrases, so it may be explicit, saying, I want to kill myself, or it could be, this is just too much. What else?
Can't do this anymore.
I can't do this anymore, so very vague. So we would want to explore that. Can't do what, right? Okay, what else might we see or hear? Okay, so different mood swings, maybe high, low, could be bipolar, might be a personality disorder if it's very rapidly changing. Anything else that we might notice? Easily agitated. Yep. So one thing that we look for is trouble with ADL, so those activities of daily living. So not bathing, not showering, but it could be as simple as just not getting up out of the bed and changing out of their pajamas. It could be something that simple that could be an indicator that person's not doing well. Those sudden extreme mood changes that we mentioned, disturbances in sleep, so it can go both ways. Either they're sleeping a lot or they're really not sleeping at all. They're having difficulty with that. Significant weight loss or weight gain. People cope differently. So some people may be struggling and they may stop eating, they may lose weight, or they may, want to eat more to help cope with that. The increased agitation, isolating, withdrawing. So maybe they're used to going out with their friends and all of a sudden they stop responding to text messages or phone calls. And so that's a little bit out of behavior for them. Self-harm. So that could be cutting, for the intent of self-harm, or it could be with the intent of wanting to die by suicide. So we have to be able to differentiate, is it self-harm or is there intent behind that? Intense worry or fear that interrupts their daily life. So maybe not wanting to go out, maybe withdrawing and isolating because they're fearful of the outside world. Making verbal threats either against themselves, so I want to kill myself, I want to harm myself, or against other people. It could be difficulty concentrating, and that could be for a variety of reasons. It could just be that they're just more on edge, they're very anxious, or it could be that they're having psychosis, so maybe they're hearing voices that make it difficult for that person to be able to concentrate on what you're saying. Again, those symptoms of psychosis, it can vary. It can be hearing voices, it can be seeing things that other people don't see, it can be delusions or paranoia, beliefs that people are out to get them, and despite evidence that you show them that that's not the case, they have that ingrained belief that that's true, and then they behave accordingly, which could be isolating, withdrawing, again, just fearful of their surroundings. And any severe out-of-control behavior, that could be excessive spending. So when we think about somebody in a manic episode, it could be they're spending lots of money that they don't have, going out and getting loans, buying cars, those sorts of things. Now, we have to keep in mind that some of these may be true for someone who's in a crisis, but also none of these could be true, right? So just because someone doesn't have one or more of these present doesn't mean that they're not in a crisis. So these are just the stereotypical things that we would think about that might indicate to us, okay, something's going on, let me explore this a little bit more and ask some questions about it. Now, when it comes to children and adolescents, there's a couple extra things that we have to keep in mind. Number one, age of consent in South Carolina is 16. How many people knew that? Now, that's not just for, I'm not going to say the unspoken thing, but for healthcare decisions, right? So if you have a 16-year-old that is in need of mental health treatment, maybe they're suicidal, they can say, I don't want to go to the hospital, and the parents can't just sign them into the hospital because of that. And that's very hard for parents to wrap their mind around. They're financially responsible until they're 18, but at 16, they can refuse that treatment. But the opposite of that is also true. So we have times where parents have their 11, 12, 13-year-old that really needs treatment, and they say, well, they don't want to go. I can't make them. They can. So that's just something important to keep in mind, is that 16-year-old threshold. The other thing is that children and adolescents don't have the developmental ability, capacity. Sometimes they can't express what's going on. They may be feeling really anxious, and they may say things like, well, my stomach hurts, or I don't feel good. They may not have the words to describe what's going on and what they're feeling for us to know that, okay, this could be the beginnings of a mental health crisis. The other thing we have to think of is a lot of times when we get calls, so I say we, I come from the mobile crisis world right now, it's usually for kids, children, adolescents who are being aggressive or acting out, maybe property destruction. And a lot of times that's a symptom of another problem. So that's not necessarily the problem. A lot of times children and adolescents may act out or behave aggressively because there's something else that's underlying that that's going on. And so we want to be mindful of that. Also keeping in mind that children are sometimes a product of their environment. They don't live in a vacuum. So if something is going on with them, there's probably something else going on in the environment. And that can make it very challenging, especially if you have a child who may be in counseling or therapy. Maybe they learn something in their session, but then they go back to the home that is still somewhat dysfunctional. And so that can make it difficult for them to continue doing well. So I really like this example when we think about youth and children who are in crisis. I'll be the first one to tell you, brain science is not my thing. But I like this because it's color-coded, so it makes it easier for me to remember. So hopefully you'll remember this. So if you think about a rabbit who lives in the woods and the forest, that is their environment, that's where they live. So if a predator, threat, something approaches that rabbit, what are they likely going to do? Probably going to hop away. Or they might just freeze and hope that the threat passes them by. And usually that's life-preserving for them, right? The threat passes on or they're able to escape. Now, if you take that same rabbit and think about probably anywhere you live nowadays where there's construction, and now that forest is being torn down. They're tearing down the trees, and maybe they're building a road or a highway through that. So now you have the rabbit in the same physical location environment, but the surrounding has changed. So if that rabbit doesn't learn to adapt to its new surroundings of the other threats that are there, if it decides to freeze when a threat approaches, what if it freezes in the middle of the interstate? It's probably going to get hit by a car, probably going to die, or if it hops away and it runs into traffic, right? So those same behaviors that used to be life-preserving for them now are not. Now it puts them at risk because they haven't learned how to adapt to their new surroundings. And so that same thing is true when we think about children. When they're acting out or they're behaving in a certain way, maybe in a certain environment, maybe at school, what's the purpose of that behavior? So we have the example here. If you have a youth, maybe they're in school and they're really angry, they're yelling, they're having outbursts, they're screaming, maybe they're getting into fights at school. So we want to look at that child and think, what's happening here? So when they're screaming, they're yelling, maybe they're in that brainstem part and they are just in that fight or flight, they're feeling threatened, they're looking for safety, right? So if we come into contact with someone and that's what's going on, particularly youth or children, that's what we want to look for, is how can we make this immediate environment safe to help de-escalate that? Now, if they start saying things like, nobody cares about me, nobody loves me, so they're starting to at least talk, they're looking for that connection. They're telling you that they're not getting that, right? So we want to see how can we make them feel connected to address that need. So maybe they start to calm down a little bit more, and now they're able to have a somewhat rational conversation with you. So they're more in that green part, the front part of their brain, where they're able to have a conversation, maybe learn coping skills. So always keep that in mind with what they're saying, their behaviors, what they're exhibiting. What are they saying to me right now? What is their need? And keep these colors in mind, and hopefully you'll be able to remember it. All right, so some keys to de-escalation. Here's a few things that you can try to do, hopefully, that will be able to help someone. One is staying calm. So if someone is really agitated, not just angry, but just more excited, one thing we want to do is try to stay calm. So I like to say we don't want to meet them in their storm. We want to bring them into our calm. So if we can maintain that calm demeanor, even in the voice, the tone that we're speaking to them, if they're yelling, we don't want to be yelling back, right? Because then it might become that who can be the loudest. But typically, if someone's upset, if they're irate and they're, have their voice raised and we're talking to them in an even tone, usually they will start to come down so that they can hear what we're saying. And so that's one thing that we're hoping for there. Another thing is to respect personal space. So, typically we probably stay like a arm's width away from someone. Most people are typically comfortable with that. That's their bubble, right? If somebody's more agitated or angry, we might allow a little bit more space. But we don't know everybody's background or history. So sometimes our inclination might be, if somebody's upset, let me go to them, let me pat them on the back, let me see, are you okay? For some people, that may be a trigger, and that may actually escalate their behavior rather than de-escalate, because we don't know if they have a trauma history or something that's happened in their past that could set them off. So just be mindful of that, of respecting people's personal space. Not provoking more agitation. Some of you may notice when I talk, I speak with my hands. For some people, that sudden movement could potentially trigger them or could potentially cause them to escalate if they're not prepared for it, or if they're already on edge, maybe if they are having thoughts of paranoia or they're concerned about their safety. Those sorts of things could be triggering for them. And also making sure that you're aware of where your hands are. That's a big thing for people. If they can't see it, they may start making assumptions about what you're doing. Case in point, I had a patient one time when I worked inpatient, and I went to do her assessment, and she was paranoid. She was starting to get agitated, and so we decided, okay, we're probably going to have to go ahead and walk her back to the unit. So I went to get my coworker in case I need his assistance. Unfortunately, he was a very large man, like 6'5", 6'6", big guy. So he walks into the room, with me, just kind of be like, hey, what's going on? Let's see if we can walk you back. And he had his hands in his pocket, just, seemed like a casual body language. She immediately hyper focuses in on his hands and is like, what do you have in your pocket? And I'll never forget it because his response was, I'm scratching my phone. Because he just had his hands in his pocket, just like, what's going on? But she's probably had previous experiences in the hospital, and what was in that pocket? Probably medication from a nurse to calm her down. So we just have to be mindful of those things that we may interpret that as just everyday behavior, just being casual, but for that person, they may perceive those things differently. And so just being aware of that. Establishing verbal contact, that's a huge one. Maybe we take that for granted. If we know somebody's name, using that to kind of focus them in on us. If we don't know, asking it, and then having a conversation with them. Being concise, this is an important one, specifically if you think about someone who maybe is having psychosis, or they're hearing voices, or maybe they're really anxious and they're having a hard time focusing. It can be very difficult for someone who has, again, using an example of a psychotic disorder, where they're hearing voices, to focus on somebody asking them 5 or 6 things at once, or law enforcement giving them multiple commands. We have to be aware of that and give shorter sentences. So if we can, instead of a paragraph spiel of what we might say to somebody else, if we can break that into 3 simple steps to get that person engaged. Active listening, sometimes we take that for granted. So sometimes that may mean listening to what the person is saying. One of the techniques that we like to use as clinicians is called either like paraphrasing, so kind of paraphrasing back to them what we hear them saying. And if you're on the same page as them, they'll probably be like, yep, that's what's going on. Or they'll flat out tell you, nope, that's not it, you don't get it. So then we'll try again. Okay, well, help me understand, what's going on here. Another one is mirroring. So sometimes if someone is saying a phrase, we use a couple words of that phrase to then kind of talk back with them. So that creates some of that connection and lets them know that we're listening and we're hearing what they're saying. And that can be validating for the person. The other thing is identifying wants and feelings. So while we may not always be able to do what that person wants, if we can identify what it is, we'll at least establish that connection with them. So if we have someone who is suicidal and they need to go to the hospital, they might not want to go to the hospital, but we might still have to take them to the hospital for their safety. Agreeing to disagree. So remember, when someone's in a crisis, we don't have to be right. Our goal is to make sure that we get them where they need to go, that they're safe. And so sometimes that means understanding where they're coming from, using some of that empathy, and again, agreeing to a disagree, right? Setting limits. So this can be difficult sometimes if someone's upset. I know we've gone to scenes where individuals have been irate, they're mad that we're there, particularly if we're there with law enforcement. Sometimes that can be a trigger for individuals just by nature of the badge, the uniform, the marked car, whatever it is. And so they're upset. So we still want to set boundaries with them that I'm here to help you. I want to hear what's going on to see how I can best help you, but can we not yell? Can we lower our voices? Can we talk? Because we don't want it to become an abusive situation where somebody's just yelling and berating and screaming at us, right? It's also not going to help us build a connection and build rapport with that person. The other thing is to give choices. Now, again, this can be difficult when the person may not have a choice, if it ends up having to be an involuntary type situation. But if we can phrase it in a way, I would much rather this be your decision to get the help that you need rather than me having to force you or take you against your will. So it's kind of how you say it. But also be mindful that if you give them choices or say they're going to get something, make sure that it is something that is reasonable. A lot of our mental health patients, when they're anxious or they're upset, they like to smoke. And so sometimes we'll say, if you calm down, I'll give you a cigarette. That's great if you can do that. But sometimes some of the hospitals they go to are non-smoking facilities and they're not going to be able to smoke. So they may be calm in that moment, but then when they get there and they can't smoke, that then is going to trigger and cause a potential escalation. So again, being aware of the choices that we can provide them and if they are, in fact, realistic. Ensuring safety. So this is maybe for lay persons, maybe not law enforcement, because y'all are typically the ones that are going to have to maybe potentially go hands-on and maybe pull somebody off the bridge. But if you're not in that role, being aware of that, right? You always want to make sure that you are maintaining safety when you're trying to help take care of somebody else. Anything else in your experience that has been helpful in de-escalating or helping somebody to calm down that you've used in the past? I got them all. Oh, posture?
Yeah.
Okay.
For us as law enforcement, we're young guys, that's new into law enforcement.
Mm-hmm.
They have the bag, and so they come with this bigger than life posture.
Mm-hmm.
Sometimes it's just humbling yourself just a little bit.
Mm-hmm.
And then within the safety reasons, so that way the person can come out. Because like you said, just the presence alone sometimes with bad gun squad car that
Mm-hmm.
situation.
Yep. Not to pick on you, but that body language, right? So you walk up and you're like, what's going on today? They don't want to talk to you. They're like, ugh. So, I think typically a lot of law enforcement sometimes, if they have like the outer vest, sometimes they'll put their hands like up here so you can see them. It's much more approachable. Sometimes it feels like. Were you going to say something else?
So this is not calm.
Oh, okay. Nah, just kidding.
So, just allowing them to speak and get their story.
Yes, that is the biggest one right there, is a lot of times when people are in crisis, they just want to be heard, right? Maybe you are the first person, maybe you got that 911 call, and maybe it's like the last call of your shift before you get off and you're like, man, I don't have time for this today. I'm going to wrap this up. But you're the first person that person has been able to speak to or connect with or tell anything to. So we have to keep that in mind, that could be the interaction that saves somebody's life or doesn't. Because if they shut off like that and they say, no, I'm fine, I'm good, and maybe law enforcement doesn't have any additional information from friends, family, somebody who called, they can only go off what they see, right? So if you close that door and don't allow that person to speak, you may never hear their story, what's going on with them, and that's potentially a life that you could save that you've now shut off. So keep that in mind. Now, some unhelpful things to say that I don't think are intended to be unhelpful, but if you tell me you've not used these, you're lying, because I know that I have.
They don't work on your wife either.
Yeah. So calm down. Has anybody ever said that? Calm down. Yeah. And usually we're saying it because we're really trying to like get some like, let's just calm down. Let's just talk about what's happening. Yeah. But it feels like it's not validating, right? Like, calm down. Don't tell me to calm down. Don't you understand why I'm upset? And so usually it has the opposite effect, right? So we just want to be aware that that could also make the individual feel like we're trying to tell them what to do. Well, just calm down. So it's not validating and it feels like we're trying to control that situation. And we don't really want to do that, right? It's not going to help us to de-escalate. What about I know how you feel? Yep, right. If you've ever had an individual who is in crisis and you say, I know how you feel, you might have a semblance of how they feel. You might have gone through a similar situation, but you don't know. You can't know how that person feels because you don't know what else they brought to this table, right? You don't know what trauma, what other events have led up to this, what else could be going on. So we never truly know how that person feels. And sometimes they'll just, not pay any mind to you saying that, but a lot of times they'll say, you don't know how I feel. And sometimes that kind of instantly breaks that connection. So a lot of times we like to say things like, I can understand why that might be difficult for you. Or my favorite is like, well, tell me more about that, because that kind of opens that door. Instead of shutting off the communication, it opens the door for more communication, to hear more of that story, to figure out what's going on, to figure out how you can best help that person. So it takes a little bit more time on the front end to get all of that out and have that conversation, but it's going to save you time on the back end and, again, potentially save that person's life. Okay? All right, what about why? Anybody ever said why? Well, why? Why'd you do that? Why'd that happen? Have y'all ever been asked why when you said or did something? How'd it make you feel? Judged. It kind of makes me feel like, well, what do you mean why? Do you think I should have said or done something differently? And so we have to be mindful of that. Again, we're just asking why, like, why did that happen? So we can figure out, well, if you did this and this happened, well, if we know the why, then maybe we can prevent that. So sometimes it boils down to the semantics and how we say things that really make a difference. All right, and then this last one, everybody's favorite, the unsolicited advice, right? You should or you shouldn't do blank. Usually it's with good intentions. Like, we may clearly be able to see the situation and say, well, you should do this and that'll make it all better. But that's usually not what the person wants, right? Usually they want to feel validated, they want to feel heard, they want to be able to say what's going on with them. They don't really care what your opinion is about the situation. Unless they ask for it. But even then, we always caution people as clinicians, because if you say, well, you should do this, and then they do that thing and it makes it worse, then they're going to be like, well, you told me to do that and now look what happened. So we really try to stray away, even when it's asked advice. We don't really like to give advice. Just be mindful of that. So when we talk about verbal de-escalation, there's really 3 little steps to that I like to try to remember. One is just listening to the person, what's going on. Again, I really like the phrase hearing their story. What is going on? What has brought them to this point that has them in this moment? So just listening. And then finding a way to agree with what they're saying, because there may be some truths in what they're saying, even if you don't 100% agree with everything, or at least validates why they may feel that way, okay? And then stating what you want the person to do. So I'm listening, I'm hearing what you're saying, I understand that may be difficult for you. Let's see if we can maybe try to find something that could help you, right? So then trying to keep it moving. Because we don't want to stay in that place of where they're just talking about all the junk that they're feeling that maybe is not great. We want to be able to do something with that. And sometimes they're directive. They know what they need to do. They know that they need to get a treatment. Sometimes they don't. Maybe they don't know what that next step is. They don't know what resources available to them. And so we want to help navigate them through that. And it really just becomes a cycle until we can get them to a place of hopefully moving on their own free will to get that treatment or that help that we feel like they need. All right, so assessing risk. Who in here has responded to or been in front of someone who is having suicidal ideations or been called for suicidal ideations? Most of you. If you haven't, you probably will at some point in your life, either personally or professionally. So law enforcement, when you get the call, You got a 911 call, dispatch tells you, I have someone saying they're gonna kill themselves. You arrive on scene. What do you say to that person? How do you engage them? You step up on scene, officer so-and-so, you, okay. How do you ask that? Do you just say what's going on? Or, okay. Okay. Anything else you all use to try to figure out what's going on the scene?
How are we doing?
Okay, how are you doing? All right, what if you get the call that says they said they're suicidal? You get on scene, that person says nothing about that to you. How are you gonna ask about that and figure out what the next step is?
Do you know what we're here?
Okay, no. I don't know why you're here.
No?
Nope.
Do you need any help?
No, I don't need any help.
No? We don't need medications.
Mm-mm.
How can we help?
I don't know how you can help me. I don't really know why you're here.
What's your name?
You should know my name. You've gotten that response. All right,
I just think because I got a call that you think about harming yourself or did you try to hurt yourself there?
okay. All right, good start. So at some point, you're going to say, well, I know I was called out here for this, right? So what we want to try to stray away from, we don't want to say, I got a call that you wanted to harm yourself. Or we don't want to use the word harm, right? Because that can be very ambiguous and that can have a lot of meanings. So someone could say, no, I don't want to hurt myself. Because they may say, like, they may be thinking, it's not going to hurt. I'm going to take a bottle of pills and I'm going to fall asleep and there's going to be no pain for me. Or they could say, yeah, I want to harm myself. And they may be thinking about cutting. And so we're jumping to the place of, oh, they're talking about suicide. They need to go to the hospital. I need to get them inpatient. But that may not be what's going on. So we always want to make sure that we ask clearly and directly about suicide. So are you thinking about suicide? Are you thinking about killing yourself? Most people are very clear, black and white, on what that is. There's really no gray area for that. Now, sometimes some people don't feel comfortable asking that because they don't know what to do with it if the person says yes. So hopefully through maybe this, some information I'm going to give you today and additional training that you seek in the future, you'll be more comfortable asking that question because you'll know how to respond to that. Now, if you don't feel as comfortable saying, do you want to kill yourself? Maybe work up to it because sometimes we may, especially with maybe younger children, I say that because we get calls for 5-year-olds who are younger asking questions like, well, do you ever wish that, you didn't wake up? Or you ever feel like you don't want to wake up? Because that could be more passive suicidality. And we still want to assess that, right? They may not be actively ready to do something to end their life, but they may be having the thought of if something happened to me, I'd be okay with that, which may lead to more reckless behavior and other things. So we just want to be aware of that. So maybe start with, have you ever felt like you didn't want to wake up? Maybe for older populations, questions like, do you ever feel like a burden? Because we get that a lot in the older populations. Maybe they've lost their spouse and they feel like their family's having to take care of them and be their caretaker and their caregiver, and they feel like a burden. So those are some questions too that you might want to ask. I really like this scale, again, color-coded. Makes it kind of easier to remember. So we always want to ask, are you thinking about suicide? Have you thought about suicide? In the last 2 weeks is usually kind of a time frame for us that we want to be cognizant of. If they say yes, then we want to continue to ask more questions. Yes. So we want to know one time frame is it happening. If they say no, not great because they're obviously still in distress, but okay, we're not talking about suicide. Let's see how else we can help you. But if they say yes, then we want to ask further questions. We don't just want to leave it at that. Are you thinking about suicide? That's terrible, right? We want to find out what's going on. Do you have a plan? Have you thought about how you would do that? How accessible is that plan? Do you have a timeline for this? Someone who says that they're thinking about suicide, they have a gun in their nightstand, they're waiting for their spouse to go to work this morning so that nobody would be home to stop them. That is a much red, high risk level scenario versus someone who says, yes, I've been thinking about suicide for a couple weeks now. I'm waiting for my divorce hearing to go through, and if I lose custody of my child, I just don't know how I could deal with that. That's a little bit more far off. We have some time. There's time and space between that. Is it risky? Yes, we're still in that moderate risk because it is going on, and it's conditional on if something else happens, but we have more time to intervene versus someone that is answering yes to all those other questions. It puts them in the high risk red zone. But it's very important to ask the question, every time. Even if you're not sure if it's going on, the worst they can do is say, no, I'm not thinking about that. And I just want to point out, it is a common myth that if you ask somebody about suicide who's not thinking about suicide, that now they're going to think about suicide. That doesn't then become an option. Just like if I say, hey, do you want to give me $1 million? You're not going to be more inclined to give me $1 million because I asked you. I didn't just plant that idea in your head. So don't be afraid to ask because you're afraid that that's going to give them an idea. Always ask the question. All right. Who is familiar with 988 or has heard of 988? All right. Who has not? Okay, I just wanted some people to raise hands. I just want to see if y'all didn't want to raise your hand or if you just didn't know. All right, so who's heard of the National Suicide and Crisis Lifeline? It used to be the 1-800-273-TALK. So that is now 988. So legislation was passed because if someone is in a crisis, it is very difficult to remember to dial 1-800-273-TALK, right? You're trying to figure out what day it is. You're in distress. And so legislation was passed that the idea is it's much easier to remember a 3-digit number, 911, for medical emergencies, high risk, violence, and then 988 for mental health emergencies. So it's the same thing. It's an additional resource. But with that change, so it's not just the National Suicide Lifeline anymore, it's now the National Suicide and Crisis Lifeline, because they want to open it up not just people who call who are actively suicidal, but people who are just in distress. So with that, it has become a change of a care continuum. So someone to call, someone to respond, and a safe place to go. So someone to call, currently 988. Hopefully every state has set up their 988 call center so they have somebody who can take that call. Fortunately in South Carolina, we have mobile crisis, so we have someone to respond. So in South Carolina, all 46 counties, we have mobile crisis teams. If the 988 call centers here in South Carolina get the call, they're aware of mobile crisis and they know that they can send the mobile crisis teams out to go and respond. And then a safe place to go. It's really changed to a safe place to be because there's also the idea that we can make somebody's home a safer place too by means restriction and things like that. We don't always want to have to send somebody to a higher level of care if they don't need that. But here in Florence, so a safe place to be could be Darlington Behavioral Health. It could be the emergency room, depending on severity. It could be the crisis stabilization unit that they're working on building. So it's somewhere to go to keep that person safe. So that's really the goal, is that it's this continuum. It's not just someone to call, and then if they need someone, there's nobody to go. It really is a full care continuum.
I think I understand too that they also have specialties for veterans, LGBTQ,
Yep, let's see.
and Spanish.
And 2 slides. That is correct. So for South Carolina, this is important for you to know. We have 2 988 call centers. So we have Mental Health America in Greenville County. They're kind of our primary 988 call center. And then the Department of Mental Health has opened our second 988 call center in Charleston end of last year. So our goal in South Carolina is we want all of our calls to 988 to be answered in South Carolina. Why is that important? Because another state is not going to know the resources that we have here. Not every state has mobile crisis teams available 24/7 to go out and respond in the community. We've had people call, and one caveat to this is it's based on your area code. So if you're from North Carolina, but you move to South Carolina and you don't change your number, you're going to get connected to North Carolina's 988. They're working on improving that, but that's how it stands currently. So our goal, we want anybody in South Carolina to be able to know South Carolina's resources and have that answered. Currently, about 27% of the calls are for suicide. So that's a huge proportion of calls that are for a variety of other things that may be distressing to an individual, not just suicide alone. It could be substance use, it could be domestic violence, other relationship issues. It could be difficulties at work, workplace stress. I mean, it's the spectrum of things that people are calling for, which is great. Because before, maybe they felt like there was nowhere to call because it was the suicide hotline. But now it's the suicide and crisis lifeline, and it's open to anybody to help get them the care that they need. So when you call 988, there are a variety of options. So 1, you press 1 for veterans, press 2 for Spanish speaking, and then more recently they added 3 for the LGBTQ plus 25 and under because they've identified that as an increasingly high-risk population. September of last year, they expanded it to include deaf services. So individuals who are deaf or hard of hearing have the ability to also utilize and access 988. But mostly when somebody calls 988, they can expect that they're going to have a trained call taker who is going to listen, who's going to validate, who's going to empathize with them, and hopefully connect them to the care that they need, which is important. And another piece that they do is they add follow-up services. So if someone is suicidal, they'll ask them, hey, do you want us to call and check up on you tomorrow and see how you're doing? So there's that follow-up piece. And here in South Carolina, we actually got funding specifically for those positions that we have people, that is their primary goal, is to follow up with people to make sure that they're not still in crisis and they got connected to the care that we referred them to. All right, so who has heard of mobile crisis? Okay, so some of you might learn some things today. So mobile crisis is in South Carolina, available in all 46 counties, 24/7, 365. We currently have 18 teams across South Carolina. So the way that we're divided up, our agency, if you look at the state, the different clusters of same colored counties, that is served by one mental health center, and each mental health center has a team. So that's 16 mental health centers. Charleston and Dorchester County, they have 2 mobile crisis teams, 1 for each county during the day. And then our 18th team is deaf services. So we actually do have a deaf services team that's on call 24/7 with our mobile crisis team, should we have someone who's deaf or hard of hearing and in need of those services. Now, we have 2 clinicians that go out and respond. So we are a co-response model, so we do only respond with law enforcement. The reason that we do that is because we do respond if somebody has a gun and is actively suicidal or has weapons or is threatening or violent, we still go because we have law enforcement with us. Whereas some other states, they may not respond to those calls as mobile crisis because it's too high of a threat level. But we are a co-response model. We have clinicians of 2, so at least 1 master's level clinician who's able to do that clinical master's level crisis intervention and assessment. Typically, it's also a 2nd master's level clinician. We're increasing expanding our teams to hopefully include peer support specialists in some of our counties because we understand the value that they bring by having that lived experience and expertise, not only to connect with the person who's in crisis, but also to give information and education to that person's family members. So we're available, like I said, 24/7, 365 throughout the whole state of South Carolina, and anybody can call. So the person can call for themselves, law enforcement can call us, or a third party can call on behalf of somebody that they're concerned about. The only caveat to that is, 1, we have to have a known location. So we can't just, if somebody texted and said, I want to kill myself, we can't just go on a wild goose chase for that person. We're going to say, we need you to call 911, see if maybe they can locate the person, and then call us back and we can come out and we can do that assessment. The only other place that we don't respond is actually in the emergency room. So if somebody's already in the hospital, in the emergency department, we don't go in there. That's really duplication of services. The emergency room can handle that. But anywhere else, we will go and we will respond to do that assessment. This is our number, 833-364-2274. And so what do we offer as mobile crisis? So again, we have master's prepared clinicians that can do a clinical level assessment. So they're assessing a variety of things. They first want to know, what's the time frame that this is happening? Because we've gotten calls for individuals where family has said, my uncle is out in the middle of the road and he's naked. And I was like, oh, when did that happen? I'm like, well, that was last week. And I'm like, okay, well, where is he now? They're like, oh, well, he's in the back room taking a nap. I'm like, okay, well, what's going on that sparked you to call us right now? I'm like, well, it's just been going on for a while and I want to get them some help. Great, I can point you to that direction. That's not a mobile response, but I can tell you what the next steps would be for that. So we want to know that time frame. For us, we're looking for imminent risk. So has something happened in the last 24 hours or is something likely to happen in the next 24 hours if we don't do something to intervene with this person? The other thing is, what are the current stressors that's going on with this person that we maybe are aware of or maybe we're not? So just because someone has a certain mental health diagnosis doesn't mean that's the reason that they're in crisis. There can be other things that are going on, relationship issues, they've lost their job, their power bill or their electricity is about to be cut off. There can be a variety of things that compound what's going on with that person that's actually the crisis. And so if we can identify that and give them resources to address those additional stressors, that can help to de-escalate the crisis. So we really want to know what's going on that led them to this point today. The other thing is changes in behaviors. So we call that their baseline. So we may have someone that maybe at their baseline, they hear voices or they believe that they're Jesus. That doesn't mean they're harming anybody, right? That's just their baseline. That's their day-to-day functioning. They may be coming into the mental health center a couple days a week. They're compliant with their medication. That's well for that person. We have one patient, for example, she has delusions or paranoia about her neighbors zapping her with their cell phones through the walls. And sometimes she walks around wearing diapers because she feels like it protects her from that happening. Now, if you see that, you might say, that's odd. Some people might say, she needs to go to the hospital. She needs help for that. That's her baseline. Now, she may get to the point where she decompensates and maybe she's threatening her neighbors. Maybe she's going and knocking on their doors. That may be an escalation. That may mean, okay, maybe there's something going on here that she needs to go to the hospital now. So we're really looking for that deviation from their baseline. Their history of treatment and willingness for treatment. So is this someone who has never had mental health treatment before? They don't know it's available. Or is this someone who is a friendly face or a friendly voice that we see or hear from a lot that's constantly in and out of the hospital? That's important for us to know. And are they willing for treatment or are they not? You can have someone who's suicidal with a plan, intent, all of those things, and they're willing to go to the hospital to get help for that. Great. But you may also have that same person and they're refusing, I have the right to do what I want to do. You can't make me do that. And that becomes a situation where we might have to step in for that person's safety. Substance use and medical history, we always want to be mindful of that. Anytime we're trying to determine if something is psychiatric or not, we always want to rule out medical. We want to rule out substance use. So does this person have a known history of substance use? Have they currently or recently used anything that we're aware of? Do they have any medical concerns? It's very rare that somebody in their 70s is all of a sudden going to develop psychosis and schizophrenia. It's usually, a UTI or some sort of medication change that's medically causing them to experience that psychosis. So we always want to ask those questions to see if we can figure out what might be going on there. And then the last piece is the social support. So do they have friends, family members, a church member who is willing to stay with them, keep them safe, bring them to the mental health center for an assessment? Do they have that third-party person that can help get them to where they need to go? Or do they have nobody? That's going to be important on whether or not we can maybe safety plan with that person or whether they're going to need a higher level of care. So I think it's important to know when mobile crisis is called and we do respond, what the expectation is of what that looks like and what we're able to do. So the first is that we kind of have the expectation that law enforcement is going to essentially clear that scene to make sure there's no weapons or things like that readily available. Now, we're not saying search their house. I know that's a big thing. It's like we can't search. We're just talking about plain view. Is there anything that person could grab that would put either themselves, officers, or our clinicians at risk? Then we're going to do our clinical assessment. Our mobile crisis teams will then staff with their admin that's on call to determine, is there an alternative disposition for this person? Do they have to go to the hospital? Can we safety plan? Can they come into the mental health center? Let's kind of weigh out what our options are. We're going to determine what our plan is. We're going to inform law enforcement of what that is. Do we need them to transport? Do we not? And then if we can do a safety plan, we'll do that. If not, do we need to get a detention order? Do they need to take them into protective custody? What are our other options? These things are important for people to know whenever we're deciding whether or not someone should be involuntary or whether they can go on a voluntary basis. So the first one is, again, that 24-hour imminent risk. Is that present? Is there imminent threat for this person? The other one is inability to care for self. So if you've ever seen commitment papers, there's 3 options on there. There's 1, threat to self. There's 2, threat to others. And there's a third one that's basically inability to care for self. And so that is usually a catch-all for someone. Maybe if they're psychotic, they're not threatening to kill themselves or anybody else, but they are clearly not taking care of themselves. They are decompensating. They're unable to function, basically. And so we look at that. We're doing mini mental status exam. Are they alert and oriented? Do they know who they are, where they are? Do they know the year? Do they know those sorts of things? Are they alert and oriented? Can they have a rational, coherent conversation? Do they have no idea who they are? We're also looking at risk and protective factors. So someone may have several risk factors, like they have a lot of stressors going on. Maybe they've lost their job, maybe they're drinking, and maybe they're also having suicidal thoughts. But they may also have some protective factors that outweigh that. So they have very supportive family, they don't live at home alone, they're willing to get treatment. If those protective factors outweigh the risk factors, we may be able to safety plan with that person and not just necessarily send them to the hospital or a higher level of care if they don't need that. Again, what supports do they have available? Is it appropriate to safety plan? If you have somebody who has a lot of risk factors, they're not really cooperative, they're not willing to engage, that's not necessarily going to be the appropriate route for that person. Again, treatment history and compliance, their willingness. Power of attorney, who has guardianship, that's very important, especially older adults. Is there somebody in the family who has healthcare power of attorney that can make these treatment decisions? If it's a child in DSS custody or there's a foster parent, who has the treatment decision capacity for that child? Is it DSS? Is it the parent? Is it another guardian? We need to know that. We need to know who has the capacity to make those decisions for that person. And then, again, we staff with our admin to make sure that we know. Some other things that are important factors for us to know: dementia, Alzheimer's, it's very difficult for us to say, okay, this person needs to go into the hospital right now because of their neurocognitive disorder, because it's going to progress, it's going to progressively get worse, and that it's very hard to say this is an emergency now because of that specific disorder. Autism spectrum disorder and some of the intellectual disabilities, that can also be challenging. Particularly, a lot of times if we get calls for mobile crisis and someone is on the spectrum, by the time we get there, they've de-escalated. They're calm, and there's not a lot that we can do in that moment. And substance use is also very challenging, and to a degree creates a patient rights issue. If you have someone who is drinking, who is intoxicated, they're threatening suicide, and we send them to the hospital, take away their rights, force psychiatric medications on them, all because they're intoxicated, when really there's nothing else going on there, that's potentially a patient rights issue. So a lot of times we have to wait for that person to sober up, reassess, and then determine, is the suicidality still present, or was that the alcohol talking, essentially? Now, if we don't get a detention order, some of the other things that we may be looking at, one, safety plan. So again, what caused this today? What can you do if these thoughts come back? Who can you reach out to? Who can you call? Where can you go? Making sure they have those things available to them. Resources, do they need a shelter? Do they need emergency food bank? What are the other stressors that are going on they need resources for? Is there another agency that's more appropriate? Maybe it's Circle Park. Maybe it's actually drug and alcohol that's the bigger issue here. And maybe the secondary referral is mental health. Helping to facilitate voluntary transport. So if someone's willing to go to the hospital, we can call and try to get them a bed. Referring to the mental health center if they've never been and they just want to be screened to see if there are services that are appropriate for them. And then finally, judicial. So you may have someone that may benefit from mental health treatment, but it's not an emergency and it's not a crisis today. There's a judicial process for that that's non-emergent that you can get that person the help that they need without saying, right now I need you to go to the hospital and be assessed. And so I would consider that as an option. Now, an idea for mobile crisis last year in 2023, our call center got over 31,000 calls to us for individuals who are in crisis. About 30% of those were crisis, so actually needed some sort of higher level, some sort of mobile response. We had over 4,000 mobile responses throughout the state, so we were averaging close to like 300 a month. Last year, it was closer to 400, and now it's over 400 a month. So we're steadily seeing an increase in the one, call volume, and two, the amount of us actually needing to go out and respond to address the crisis. 1,600 referrals from law enforcement. Annually, that number does increase, which we appreciate because we know that law enforcement and first responders are getting the calls. It's just a matter of whether or not mental health is getting the call to help assist with those calls. Almost 3,000 diversions from the emergency room, hospitalization, or jail, where we're able to go out, de-escalate, safety plan. And our average response time is about 48 minutes. To put that into perspective, that our agency goal is 60 minutes or less. We have exceeded that. I know it can be difficult for first responders, like they're ready, like I have calls pending, I need to get to the next call. But you also have to remember, do you take a little bit more time on the front end to figure out what the actual need is? Or do you go out to this house 4 and 5 times that night because you're getting called because you didn't actually address the crisis? Also, SAMHSA's national best practice for mobile response is 60 minutes for urban, 2 hours for rural, and 3 hours for frontier. So throughout our whole state, we are on average less than 60 minutes. So it seems like a lot, but we're well within the national standard for that. So how we can help law enforcement, one is we share the responsibility for getting that person the help that they need. So getting them where they need to go the first time instead of being passed back and forth between the emergency room and being discharged and calling 911. We're helping get them to the most direct care that they need. The other is consultation. We encourage law enforcement, if you don't want to wait for us to come out and respond, still call us because we have information. If you're getting called, that's a crisis. So HIPAA doesn't apply in that moment to us. We can give you the information about that person that you need that may help you decide where that person needs to go. And again, for any person that's experiencing suicidal, homicidal ideation, psychosis, any of those things, we can help with. To kind of summarize our capabilities and limitations, one, we can provide that assessment and referral. We can help develop safety plans. We can do follow-up with them to make sure they're getting connected. We can help with facilitating them being admitted to the hospital. We don't transport individuals, so you can't call mobile crisis to take somebody somewhere. We don't do that. We don't provide or adjust medications. Our mobile crisis teams don't have nurse practitioners or psychiatrists on call with us. You know, they can have that done at the mental health center, but mobile, we don't do that. We don't provide services without law enforcement on scene with us, and we cannot safely and accurately assess someone who's severely intoxicated. So if they're slurring their speech, they're not really alert and oriented, again, we can't differentiate, is this a substance use or is this really psychiatric? So just be mindful of that. All right, so who in here has heard of emergency protective custody? All right, what does that mean? Who's involved? What does that entail? Who is it for? Children, juveniles, vulnerable adults. Who's involved? Do you have to call anybody else when you EPC somebody? DSS? Okay. Who's heard of protective custody? Is it different or is it the same? How's it different?
But emergency protective custody is when you're on scene and the actual officer has to arrive to the hospital with the actual ambulance provider.
Mm-hmm.
So, and the parent.
Mm-hmm.
In that particular instance, I think protective custody may be more. I'm not sure if it's different, but I think protective custody is when maybe, you get a call and you're not possibly emergent.
Mm-hmm.
And then you say, okay, well, it's, you know, we can put me into custody because maybe my boyfriend is missing abuse or something.
Okay. Good guess. So, protective custody is for those who are mentally ill, impaired by substance use. It gives law enforcement the same authority to detain that person and transport them to the hospital with no other paperwork required. By statute, you have the ability to do that as a certified law enforcement officer. And many officers, agencies, departments don't know that. So it's important to know you don't have to call DSS. DSS is not involved, so you don't have to wait for them to come and respond on scene. It's just a separate statute. If you believe that the person is at imminent risk to themselves or others because of their mental illness, substance use, something going on, you can take them into custody and you can transport them to the hospital to be assessed. There's only a few important things there that you have to do. One, tell the person they're not under arrest, right? I'm taking you into protective custody because I'm concerned about your well-being because of ABC. So you have to be explicit about that. You're not under arrest. I'm taking you into protective custody. Two, you're immune from civil liability for taking that person to the hospital as long as there's no gross negligence to that person and them being harmed. So you're allowed to use the amount of force necessary to get them, to detain them and transport them to the hospital for help. So that's important for you to know. So it's not the same as EPC. It's not for children. It's not for vulnerable adults. It doesn't include DSS. One hesitancy for a lot of agencies with this is there's not a formal form, right? Like commitment papers, there's a part 1 that you fill out. There's a part 2 that a doctor can do or a detention order that probate can fill out. There's no paperwork necessarily required for this. Some agencies have them. If your agency doesn't have one, you might want to get one just as maybe to add to your report, to supplement your report. But keep that in mind. The other option would be a part 1 or getting the detention order. Of course, that's reliant on one, mental health or somebody coming out, doing that part 1, filling that out, getting it notarized. You have to call a probate judge. They have to issue the order of detention. So that's going to be a little bit more time consuming sometimes. But if you're not sure and you want mental health to do that assessment, call Mobile Crisis. We'll do that assessment for you. If it's clear, it's obvious to you this person is in distress, they need help, I would encourage you to use protective custody. However, I would consult with your agency. I don't know what your different agency or department policies are on that. If you don't have a policy with that, you might want one because it's meant to help the community and it helps you do your job better also. If you do choose to take them into protective custody, it's very important to make sure that if you have paperwork, you get it done. I would include it in your report. You could also include that you inform them that you took them into protective custody, they weren't under arrest, just so that you cover yourselves in terms of that statute. If you call Mobile Crisis and Mobile Crisis comes out and does that assessment, then I would encourage you to also put that in your report, that a clinician came out, did an assessment, this was their determination, this is what they said. I'm gonna skip this one. I will make these slides available so that you all can have it, but I'm not gonna have time to cover it. So I'll wrap up here. And that piece that I skipped over is also something that I can help with, so I'll talk about that. So the first one is, you don't want your training to stop here, right? you want to continue to grow it. Things are always changing, even mental health. We get new updated DSMs with different diagnoses, and that changes. That happens on a rolling basis, so you want to stay up to date. So one option is crisis intervention training. Anybody heard of CIT training? Hopefully you have. So I would say reach out to me, but I have Sherry Clouden here with NAMI. She's actually the CIT coordinator for the state. So if you're interested in having that provided for your agency, I would encourage you to reach out to her. They're already scheduling into 2025, so get on the schedule. It's a 40-hour week-long training. It's Criminal Justice Academy approved. They also have some shortened versions. So if you're like, I don't know if I can get all my people off the street for that long, you do have some other options. But again, reach out to Sherry right here. Raise your hand. Find her afterwards if you'd like. The other option is myself or our mobile crisis teams for local departments. We will go and we will do roll call or shift change trainings, talking about mental health, talking about some of these things that I covered here, just to make your officers and deputies aware of what's going on. We're more than happy to do that. If I'm available, I'll do it. If not, I'll find somebody local that can do it. Third, making sure that you're doing your ACADIS mental health updates. Don't just click, actually listen to it. Mental health first aid is another option. Assist applied suicide intervention skills training. That's a 2-day training. I would encourage that. The thing that I skipped over was something that I did recently, but it's basically the intersection of mental health and negotiation. So if your agency or department has a negotiation team, hopefully you're utilizing mental health professionals on that. And if you're not, I would encourage you to talk to your local mental health center about that or reach out to me. I recently did a training on that, talking about how mental health professionals can assist with that and how officers who are responding to a negotiation scene, a barricaded subject, things they can be aware of, questions they can ask, all that good stuff. So be more than happy to assist with that if you want to reach out. Here's my contact information. Questions? No, I nailed it. All right.